Dr.
We are
Ajay
live.
Dudani, he had joined, but I can't see him here.
We are live.
Okay. So good evening and welcome you all to the first academic session of Noida Ophthalmological Society. We have started this year with a program on retina. There is a symposium which will be held from 7 to 7:45 or 7:50, followed by a case presentation session which will be from 8 to 9 p.m. The first session is a symposium on breaking barriers in the management of neovascular AMD. I have with me Dr. Anshu as the co-chair, and we have invited speakers, Dr. Aniruddha Maiti and Dr. Ajay Dudani. Let me give you a brief introduction about our great faculty which we have today. Dr. Aniruddha is heading Shushruth Eye Hospital in Calcutta. He did his MBBS from Calcutta National Medical College Hospital, did his post-graduation from Regional Institute of Ophthalmology, Calcutta, followed by his fellowship at Aditya Jyot Eye Hospital. He has been a practicing vitreoretina surgeon since over 1.5 decades, has got a large number of presentations and awards, and his key areas are electrodiagnostics, retinal detachment surgeries, macular surgeries, and neuro-ophthalmology. Dr. Maiti will be joining us in a short while. So welcome, Dr. Maiti. He should be here in another 10 minutes. Then we have Dr. Ajay Dudani, who is a prolific vitreoretina surgeon from Mumbai, a good friend. He has been fellowship trained at Shankar Netralaya, followed by his fellowship with Ando at National Lagoa Hospital, Japan, many years back, and he runs his Zen Eye Center in Mumbai. I believe during the pandemic, he has also become a great singer. So welcome, Ajay. He has large number of presentations, and he's a great person to be with, a very lively person, and has got a very critical insight into vitreoretina. I have with me Professor Goel, Dr. Atul Singh, Anubhav Goel, Prashant Jain, and others who have joined in. We welcome you all. And the questions which are being asked by the audience, it'll reflect in the chat box, or if it might come to me, and I'll ask the speakers the questions during the session. So I have to start the session with a presentation followed by presentations by Dr. Maiti and Dr. Dudani. So I'll just start sharing my screen. Can you see my screen?
Yeah.
Yes, sir.
Okay, right. So the overcoming treatment barriers in neovascular AMD. Now, since we are going to have a lot of people who are general ophthalmologists, I'll try to speak in a way that is understandable by all. So we all know about neovascular AMD, how does it present, and this is just a pictorial representations of a choroidal neovascular membrane with drusen, heme, lipid, extrafoveal CNVM, IPCV, and CNVM associated with pathological myopia. Having been in practice since a long time, I have seen how over the period of time, things have changed. When we were doing a residency way back in JIPMA, we used to call it a dull phobia, and the CNVM was actually not diagnosed. AMD was not very well recognized. and we used to call it macular degeneration, and nothing much could be done for those days. Then came up the macular photocoagulation study with in early 1980s with thermal laser, where basically we were trying to save some vision and not enhance vision. But the patient usually had a loss of central vision, but we would say that you will have preservation of your peripheral vision, though you may lose central vision. Then was photodynamic therapy, which was expensive, but still we were not able to enhance vision. The revolution came in October 2005 when for the first time intravitreal injection Avastin was given by Dr. Rosenfeld from Bascom Palmer in October 2005, and rest is all history. So after that, we have discovered newer barriers, and so what is the optimal treatment in 2021? There's been an evolution in the treatment protocols from a monthly regime to quarterly regime, bi-monthly regime, a PRN that means as and when required, or a treat and extend, which is becoming more and more popular because it has got a scientific basis. But mostly in India, we follow a PRN regime. If you look at what difference anti-VEGFs have made, if you look at the year 2000, the amount of blindness because of neovascular AMD, and look at the amount of blindness which is there in 2010, and there's a gradually downward decreasing this thing. It's almost 50% reduction in the incidence of neovascular AMD. It is also seen that if there is a loading dose, patients have better visual acuity as compared to those who do not have a loading dose. Then it was shown that it is the most difficult part, which is actually the unmet need for the patients, is to monitor their visits, and to give them treatment in such a way that their visits to the OPD become less. So, how do we optimize anti-VEGF treatment? What does optimization mean? It means maximal benefit with minimal dosage, which basically means that you need to control the disease. Am I audible?
Yes, yeah, yeah, yeah.
Okay, okay. So there has to be a reduction or absence of exudation. We should reduce the amount of fibrosis, maintenance and improvement of visual acuity, reduction or absence of recurrences, and reduction in number of injections over time. So this is very important because you are taking away time or you are benefiting the patients as well as the attendant if you're calling them less. So that means you have to treat them early, treat them sufficiently, and treat them in such a manner that the treatment is a sustained response. That means a single injection lasts for a longer time as compared to giving them more frequently. Now, if you look at the treatment protocols, whenever a patient comes in, so many things need to be done: visual acuity, fundus examination, OCT, photography, autofluorescence, angiography, ICG if required. And then we have numerous protocols that have to be followed. Now, it was seen in the ASRS PAT survey that most retina specialists believe that if we give a discontinuous anti-VEGF treatment, it resulted in poorer visual acuity. And this was probably because the logistical issues of patients not coming on time, or the physicians not being available, or whatever may be the reason. So it is better to have an organized way of giving treatment on a regular basis, which is what Treat and Extend wanted to develop, so that when the patient comes in, the investigations are done at the same time as well as injection. The only problem is that in our country, because of the disparity of the financial status, many people believe that PRN may be a better option. Now let's look at the fluid which is present. Now the most important hallmark in neovascular AMD is the presence of fluid, and that's what we look at in the OCT. It could be subretinal, it could be intraretinal, or it could be sub-RPE. Now this is just to show you. You have the subretinal fluid, the subretinal fluid, the subarachnoid fluid, and the intraretinal fluid. Now, it's the intraretinal fluid which is the most important as far as the reduction of visual acuity goes. There was a fluid study, we'll not go into too many details of it, but just to tell you that this fluid study looked at an intensive group and a relaxed group. What was the difference? That intensive group was targeting to achieve a dryness of the retina versus the relaxed group, which said that less than 200 microns of subretinal fluid was well tolerated. So uh, uh, this is how it was done with the 3 consecutive monthly injections, and then the target in the intensive group was to dry the macula, while in the relaxed group was to achieve a level where the subretinal fluid is less than 200 microns. Whenever it is more than 200 microns, the patient required treatment. And the disease activity was managed by these factors, which included visual acuity, retinal hemorrhage, presence of the amount of fluid, presence of fluid within the retina, intraretinal fluid, and the subretinal fluid. So what they found was that in the relaxed group, as well as in the intensive group, the visual acuity improvement improved almost similarly over the period of 24 months, despite there being some amount of fluid being present. But when they looked at it a little bit more closely, they found that though there was no significant difference between so this is the relaxed group and this is the intensive group, the gain in visual acuity at 24 months was marginally better in patients who had, where an intensive treatment was followed. But then we looked at the presence of an unresolved SRF may lead to formation of an intraretinal fluid. So although there was no significant difference in the best corrected visual acuity, intraretinal fluid was present in higher proportion of patients with the relaxed treatment. So when these patients were followed beyond 24 months, it appears that these patients actually did worse than patients who were in the intensive treatment group. So this is what it is, that patients who had persistent or subretinal fluid at the end of 24 months and were followed subsequently, they could eventually lead to formation of an intraretinal fluid. Now, this is just to show you examples of intraretinal fluid, subretinal fluid, and the sub-RPE fluid. So a post-hoc analysis was done for this thing, and they found that the dry retina tends to provide a long-term visual acuity gain. You can see here that these patients had a drier retina, so there was a significant improvement in visual acuity when followed for a longer period of time compared to those who had a persistence of some fluid. So presence of fluid leads to visual acuity decline. Now that is an important decision, which is indirectly indicating as to if we have a drug that can dry up the retina faster, keep it dry for a longer time, may actually be the answer to a situation where a drug can be given over the time and it does not dry the retina. So there was a positive correlation between the absence of fluid and visual acuity gains and absence of intraretinal fluid when this was charted out in these patients. Now, what are the barriers to optimum treatment of neovascular AMD? So this is good initial clinical examination. That means patients should have a detailed examination initially, which may include an OCT angiography, and maybe FFA and ICG. We should be able to select the appropriate drug based upon its cost, duration of activity, and effectiveness. We should be able to decide the drug regimen, that is treat and extend or PRN, and we should work out a logistics which is appropriate for the patient and the doctor. We have these drugs available at this point of time, and the newer drug which we are going to discuss today is brolucizumab. We'll have presentations by Dr. Maiti and Dr. Ajay Dudani. Let me give you a brief about the brolucizumab. This is basically a single chain antibody fragment, which, being a smaller molecule, a large amount of molar dose can be given at a time into the eye. And this was what was shown by the Hawk and Hoyer study. This is the Hawk study, which had study locations globally, including the US, and you had Harrier, which was located outside the US, and there were about 408 study sites. These were some of the inclusion criteria. I'll rush through some of these things because we want to hear our invited speakers and don't want to take away too much of your time. Basically, this is how these patients were enrolled. They were very balanced between brolucizumab 3 milligram, 6 milligram, and aflibercept 2 milligram. And this is the Harrier, which is brolucizumab 6 milligram and aflibercept 2 milligram. So this was what was the treatment protocol, where after the initial, so this green ones is the aflibercept, and this is brolucizumab. The aflibercept was given at 2 months interval, at 8 weeks interval, and brolucizumab at 3 months or 2 months interval, mostly at 3 months interval. That means after the first 3 injections at 20 weeks, 32 weeks, so there's a gap of 12 weeks here. Now, in case a disease activity was detected, the patients from brolucizumab was switched over to an 8 weeks interval at whatever time this happened. And it was found that if a patient did get into an 8-week interval, it was difficult for the patient to get back to a 12-week interval. And this is just to show you that Hawk and Harrier were perfectly balanced across the treatment arms, including both for the 2 different doses of brolucizumab as well as aflibercept. It's been shown by the study that the brolucizumab is non-inferior to aflibercept in mean best-corrected visual acuity change from baseline to week 48. The average change in best-corrected visual acuity from baseline to the period of 36 weeks and followed up to 96. So it was found that most of the patients in the Hawk and Harrier study, a significant portion of the patients were dry by about 32 weeks. There was a larger portion which was dry about 37 weeks, and more than 50 percentile were dry at this particular point of time. It was also seen that those people who responded within the first 12 weeks of treatment and dried up remained on the 12-week regime for a longer period of time. So both Hawk and Harrier brolucizumab met the primary endpoint of non-inferiority for a change in best-corrected visual acuity from baseline at week 48, and this was maintained at 96 weeks. Now, this is interesting to see that the proportion of patients who gained more than 15 letters from their baseline or best-corrected visual acuity of more than 84 letters was higher in the Hawk as well as Harrier as compared to aflibercept. And it was also seen that there was a greater fluctuation of the central subfield thickness in the aflibercept group as compared to the brolucizumab group. And we know that these fluctuations in the central subfield thickness is actually responsible for a long-term drop in vision for possible development of fibrosis in that area. So the Hawk and Harrier patients of brolucizumab had lesser amount of intraretinal fluid and subretinal fluid at 16 weeks, 48 weeks, and 96 weeks. The green one is aflibercept, which clearly shows how this is for SRF and intraretinal fluid for Hawk, and this is for the Harrier, which shows that patients on aflibercept had a higher chances of having fluid at various time points when they were monitored. And similarly, when we look at the anatomical outcomes in terms of percentage of patients who had intraocular fluid and who achieved with considerable proportion of brolucizumab 6 milligram as compared to 3 milligram and as compared to aflibercept. So let me just try to sum it up rapidly because we would like to see the cases. And so basically, Hawk and Harrier showed that brolucizumab is effective. We have also learned from this that a higher molar concentration can be given in the eye. It was also shown that since this particular molecule does not have an FC fragment, it was believed that brolucizumab will possibly be less reactive. I was actually expecting this molecule very expectantly, but recently there have been some issues, and that is what we are here to discuss of the intraocular inflammation. But the way Novartis has taken it up as a challenge to investigate this matter and illuminate us is really is very admirable, because I think we will soon have an answer how to overcome this overcome this problem, and we'll probably hear from our invited faculty and how they were courageous enough to inject brolucizumab and what precautions they have taken to prevent the development of intraocular inflammation. This is just a case which has been on ILIA for a long time. I don't think we'll have so much time. I think I've taken already quite a bit of time. So basically showing that this patient has done well with ILIA, but has got a peripheral exudative hemorrhagic chorioretinopathy. Recently, the patient came as dry. Now, actually, I'm looking at injecting brolucizumab in this case. The only problem for me is that the relatives are advocates. So I will stop here sharing and would like to listen to our invited faculty. Hi, Ajay. Can you unmute yourself? Welcome, Dr. Maiti.
Good evening, sir.
Good evening. I introduced you. You were not there at that time as a prolific surgeon from Calcutta.
Ajay, is there any cost difference between brolucizumab and Eylea?
Sir, I
Is it
think
available, commercially available?
the brolucizumab is commercially available as PAGENAX, and I think we will ask Anirudh and Ajay to answer all your questions.
Okay.
Anirudh, you want to start?
Yeah, just share my screen. Is my screen visible?
Yes.
Yeah.
It's visible.
Yeah. At the outset, I would like to thank the Noida Ophthalmic Society and Dr. Ajay Arora for this kind invitation. Well, I will be sharing my initial experience with this new molecule, that is PAGENAX brolucizumab. Let's go through some cases. This was the first case. A 68-year-old male patient, a doctor himself, had a blurring of vision since last 5 months in both the eyes. He could not say which eye got affected first. There was no comorbidities. The vision in the right eye was 660 and the left eye was finger counting 2 feet. Anterior segment was unremarkable. The dilated fundus examination shows a bilateral case of a CNVM. And as you can see in the OCT, the right eye showed an active CNVM. The central macular thickness was 341 microns, and the left eye, the OCT shows a partially scarred CNVM with SRF. And seeing this OCT, we could predict that this eye might not do prognostically well. So this patient, we had advised ACCENTRIX, so the left eye and the right eye. He was given an option of aflibercept or brolucizumab. And in fact, I had discussed with, as he was a medico, we had discussed about the Hawk and Harrier study, and he was very much interested, and he was keen to have this new molecule, and I was also similarly keen to see what is the effect of the medicine, although this might not be the ideal first case of PAGENAX. But I was lucky, the patient was also lucky. The first, after the first injection, as you can see, the lesion has reduced in size, and the vision also improved to 660 to 636, and the CMT reduced to 285. And this is after one injection of ACCENTRIX in the left eye. Obviously, the vision didn't improve much, but the SRF had reduced, the lesion size had reduced. The CMT, you can see, it is reduced to 330. After the this is the OCT after the second dose of PAGENAX, as mentioned in all the Hawk study as well as the Harrier study. The PAGENAX is also given in a same posology, like monthly one injection for the 3 consecutive months. So we actually gave monthly injection. This was after the second injection, and there was a dramatic response. As you can see, it was almost complete resolution of the CNVM, and the vision improved from the initial, which was presented as a 660 to 624, and the CMT reduced to 233 microns. And the left eye, we didn't give any injections. We were just observing because there was no SRF, and the lesion is almost dried up. So this we have given the third injection, as already mentioned, that we plan to give 3 injections. So this is after the third injection. You can see almost like a normal contour, foveal contour in the OCT. The lesion is almost disappeared, and the vision further improved to 618. In fact, the patient was so excited, he actually said, why not try in the left eye? I said that this will not improve. He actually got the PAGENAX injection in the left eye, and although anatomically it was same, the patient was symptomatically better. I don't know why. So if we summarize this case, this was a treatment naive case of a CNVM at presentation 660 vision, improved with each and every injection till the third injection. As you can see, after the third injection and the follow-up after 4 weeks, you can see the vision improved to 618. So the initial, the first case was really good. The patient was very happy. So let's come to the second case. This was a 56-year-old female patient, dimness in the right eye for 1 week, and the right eye had a subretinal bleed with a huge PD, which we can see uh, in the OCT. You can see this PD looks like this was an IPCV bleed because it's a thumb-like PD, which is quite suggestive of an IPCV bleed. And the way the bleeding was there, there was a quite a almost the posterior pole was covered. So we decided by this time. I had already given 2 PAGENAX. So I thought, let's try, because we have seen in the Hawk and Harrier study that it responds pretty good, in the sub RP fluid also responds pretty good with the PAGENAX. So we gave PAGENAX for this patient, and this patient was an outpatient, outstation patient. So I was very keen to see the patient regularly. In the first week, we had done an OCT to see whether there's any inflammation. There was absolutely white eye, and to my surprise, within a week there was a reduction in the subretinal fluid as well as a PD height, and the vision from finger counting close to face actually improved to 1/60. The same patient, when came after 1 month, there was further improvement in vision to 660, and as you can see, the PD height has decreased quite a lot. This is after the second injection. You can see the PD is almost gone, and the hemorrhage has also significantly reduced. The patient is symptomatically much better, and vision improved to 636. Now this patient, we have already given the third injection. So from finger counting close to face, this actually improved in 2 to 3 months time, 636. So this were the treatment naive patient. The first was a CNVM. The next one most probably was an IPCV bleed. That time it was a COVID time, so we were not doing this any angiography. We were doing the OCT, the baseline OCT, and treating. The third case, this was a 62-year-old male patient with the dimness in the left eye for 2 months, hypertensive, anterior segment was normal, and the left eye showed an active CNVM or a PCV. I will come to it why there was a query of PCV. This was at presentation 660 vision with a PED. The CMT was 582 microns, and he was been given 3 doses of ACCENTRIX, and it responded pretty well. The vision improved to 618. There was the resolution of the lesion. But after this loading dose, when he was been followed up, after 6 weeks after the third injection, there was an recurrence of the lesion. As you can see, the vision from 618 to it worsened to 660. And this time, if you see the PD, it was actually an notched PD, which is also very typical of a PCV. So it might be the PCV lesion. So this time we advised PAGENAX, and this is a picture after 4 weeks after giving the injection PAGENAX. The vision again improved to 612. And as this was a refractory case, obviously we were not giving injection monthly. This patient has already gone more than 2 months and he is quite stable. So if we summarize this case, this was the picture after 3 doses of ACCENTRIX. Obviously, 3 doses of ACCENTRIX, it was doing good, but there was a recurrence after 6 weeks when the vision dropped to 660, and with a single dose of PAGENAX, it improved back to 612. So this was the PAGENAX after there was a recurrence following 3 doses of ACCENTRIX. Now, the fourth case, this was 64-year-old female patient, dimness of vision for the last 3 months in both the eyes. And right eye showed a scarred CNVM with a small SRF, and the left eye was active CNVM. Right eye, we had given 1 dose of ACCENTRIX, and the left eye, 3 doses of EYLEA. This was right eye, as I already mentioned, that this was a scarred CNVM with SRF. The left eye definitely was an active CNVM with a CMT 447, and the vision was visual acuity was 636. And this is after the one injection of ACCENTRIX. No further treatment was given after giving one injection of ACCENTRIX in this eye, right eye. But left eye with 3 doses of EYLEA responded pretty well. The vision improved to 612, and there was a complete resolution of the activity. But after this patient, like the previous one, had a recurrence after 6 weeks, the vision dropped down to 660. So there was a reactivation of the CNVM. This time we had given PAGENAX, and there was a dramatic response. Again, the vision came back to 612. And this patient, around 6 weeks follow-up we have already done. Till now, doing pretty good. So this was recurrence after 3 doses of aflibercept, 660 vision, improved with a single dose of PAGENAX to 612. Coming to the last case, this 78-year-old male patient had a dimness of vision in both the eyes. Right eye was diagnosed as an active CNVM, and left eye was a scarred CNVM, and this patient was very apprehensive. A little bit fluid was always there. We were doing a very quick follow-up, frequent follow-up, already had 7 doses of injection aflibercept, and the left eye no treatment was given because it's already been scarred. So after 7 doses of aflibercept, still the activity was there, because on and off this activity was still there. So we can say it's a refractory case where the CNVM activity was still there after 7 doses of aflibercept, and after giving a single dose, it actually responded pretty well. The activity reduced and the vision also improved. So the first 2 cases was a treatment naive. Then it was a recurrence following an loading dose of injection ACCENTRIX, and the fourth case was a recurrence after 3 doses of aflibercept, and the fifth one was actually an refractory CNVM who was treated with 7 doses of aflibercept. All the cases actually responded pretty well with this new molecule of brolizumab. So the take-home message, if you see the cases now, I have used almost 16 PAGENAX injections. In all the cases, there was a very dramatic improvement in all the OCT biomarkers, or rather the fluid in all compartments, that is intraretinal fluid or a subretinal fluid or a sub-RP fluid, and the central macular thickness. And lucky for the patient and lucky for me, no patients out of the 16 patients actually showed any amount of post-op inflammation, post-op inflammation, either a vasculitis or any anterior segment reaction. But definitely it is too early to say, but time will say whether this new molecule of PAGENAX is the safe and most effective drug in the treatment of wet AMD and PCV. Thank you.
Lovely presentation, Anirudh. It's really, I have a lot of questions, but I think let's hear out Ajay and then we can have combined questions. And we have time, so don't worry about that.
I will just...
Anshu, I want you, Prashant, Anshu, Ruchit, I see you there, Anubhav. You can put in your questions later on.
Sure, sir.
Just a minute, I need to share.
No? Do it.
And just for people to know that Ajay Dudani has learned how to sing well now.
No, not really.
उसको नीचे से वो दबा देना स्लाइड शो. Next one. Yeah.
Hi. So it's nice to be with friends, though it's like, virtually. We'd love to shake hands with each other, but I think hopefully this COVID should go and we'll soon be together like good old times. So I want to thank everyone for this opportunity to speak about my brief experience I have with this new molecule. So without much ado, I'll go on to my cases. This was one of my later cases. I'm starting with the treatment naive, which was I think my one of the 10th case or 12th case, you could say. So this was a 55-year-old lady, a very sort of a type A personality who presented with metamorphopsia, vision 612, N12. So I thought she was a CSR. First thing, what do you think on your mind? And she presented on examination. She had a typical sort of a CNVM, which was juxtafoveal with a spot hemorrhage, which is typical, which we see in a CNVM, which I'll show you all the image. And she received brolucizumab after discussing a lot with her husband and her also. And at 1 week, there was magic. So this was a typical CNVM, which we see where there was a spot hemorrhage. You can see there's intraretinal more of exudation. It's an intraretinal neovascularization with IRF and SRF, which is visible here. So this is how it was, and this is how it was at 1 week. I mean, there's no trace of that fluid or the lesion. You can see the whole map, which is seen there, I mean, you can't see anywhere any sort of. So then I did a high definition scan through the lesion, and here you can see there are a few HRFs, hyperreflective foci, and the slight elevation which you can see in the high definition scan. So it was almost like we gave a slap to the CNVM and it just slapped, sat down and became flat. And I saw her back again now. She came back a month later also, and she's doing equally well. So I've delayed the second injection. I'm not giving it at a month because I feel that we can, treat and extend and, keep on extending till we find that the fluid comes back, because anyway, we are seeing these patients very closely now and we are learning about them, This is a second case, a 82-year-old male whose both children are doctors abroad, and he had both eyes POAG under medical treatment control with a cup of 0.9. He had a sudden loss of vision in the left eye. So there was a massive subretinal hem with a CNVM, which we saw in this. We discussed with his son abroad, like they all speak to us on phones, And we decided about brolucizumab and gave a 0 prognosis considering his glaucoma and the hemorrhage which he had. And at 1 week, I was quite surprised. So this is how it was, that mound, as you can see. And there is this subretinal heme here, which was there, red colored. And this elevation. And this is at 1 week, and then he just came yesterday to me. You can see there's a flattening, and he said actually he could see. So I didn't check his vision 1 week. So I called him back at 1 month. And then again that it had become flatter, and you can see on the map that, this is much less here, the elevation. And he was counting at 2 meters, with a little eccentric sort of vision, but he was counting, and the heme had flattened out quite a bit. It was elevated, but now as you can see, it's flattened out in certain areas. Certain areas, there's still some element of fluid which is there, So again, him, I thought that I will extend because the lesion was looking relatively dry compared to before. This is a combined case I would share with you again. A pharmacologist father he was. So the left eye, we had treated him initially with one ranibizumab. He was a 80-year-old male with a type 2 CNVM. We gave him one ranibizumab and then we switched over to brolucizumab. And he was very happy with the first injection itself, and his vision improved to 5 meters. So this is how the story started with the left eye. This is the pre-injection showing you the elevation on the map here. And this is post-PAGENAX. You can see that the CNV actually flattens out, and kisses the RPE, and the foveal contour does come back. And this is 1 month again post-injection. He was very happy with a flat macula. And then at 2 months, we sort of, as I told you, I'm extending these patients. I think that they will, the drug will last longer. You might not necessarily, give a loading dose, but I'm still learning. I have to share my experience with you all, how I'm going about it. So at 2 months, the left eye lesion started recurring, as you can see here, and there was a bump which came up and this fluid came up. So we said, we'll do this left eye injection, but then we also always see the right eye, also the other eye, because AMD is a bilateral disease, So he had not dilated himself in the right eye. So I insisted that he goes back and dilates and comes back, I don't know why I got that thought. And this is how he presented in the right eye on that day. At 2 months, follow-up for the left eye lesion. He had a juxtapapillary CNVM there, as you can see. His vision was 6.6 and 6. So this was an incidental finding. He didn't even complain. But you can see the OCT through the lesion is showing you this elevation over the papillomacular bundle with this type 2 CNVM, which is very visible here. So 1 week post-op, again, we called him because we're calling all our patients closely, as Ajay said, to look out for any signs of intraocular inflammation in these patients. And it's almost like gone for good, with the heme also is reduced clinically. And even the left eye, which we injected again, as I told you, after 2 months, and that was not at 1 month loading dose. So then even this eye has become better. At 5 weeks, this is how he came, the right eye had almost become bone dry. There's no CNV actually visible. It's almost disappeared and this is through the lesion. I took the high definition scans to show you a little more closely. You can see here, actually it's just flattened out beautifully. You can just see this one knob here above the RP. So there's no net. And, I saw that most patients of AMD, I feel, we tend to miss out the anterior segment. Most of these old patients are pseudo-phakic and they all have some element of PCO, which, we miss out in our hurry of treating the AMD. So he had a diffuse PCO also. So I yagged him in this follow-up at 5th week, which he came for post-second injection. And then post that, he was quite happy even with the left eye, because he was complaining my left eye is not that good, doctor, because now he expects a magic in the left also like the right, but you can see that overall the lesion is very good and the foveal contour is there, so post YAG he did much better, I felt in the vision wise also, and his, contrast improved. This is one of my prize cases. She's the first lady whom we treated. So she's a 64-year-old lady with an occult large CNVM, a large PED. She had multiple past interventions. As you can see, she had received 24 ranibizumabs, 5 aflibercepts, and the first brolucizumab was injected on the 30th of October, and the second a month later. Now, why we injected it a month later, we'll show you the story. So this is how it starts with a PED in 2018 October. After 2 injections, you can see the flattening which is there. But then it came back with a vengeance, like how all these PEDs come, So she kept on receiving injections monthly, month and a half, ACCENTRIX, then we switched to Eylea.
I think we have lost Ajay. Dudani, is it? Sunil, can you please check if why the connection with Ajay is gone?
Sir, he's logged off.
He's
I think
logged off?
the issue. Yes.
Okay, so maybe maybe his this thing was not charged. I will call him, but anyway, we can start discussions. Anybody has any questions for Dr. Maiti? I would like to ask you. See, your first two cases were treatment naive cases.
Right.
All of us have, and your. So I want to ask specifically, whenever you are deciding to inject, Ajay is there. Ajay, you have to. You were certainly locked out.
Yeah, because I think we were. Now is it clear,
Yeah,
Ajay?
because
I'd say
you
Can you all see the
locked out.
slides now?
चलो हाँ आप अभी स्लाइड्स नहीं आ रही प्लीज शेयर
Okay, I'll share it. Huh? I'll share it. Yeah, 1 second. Share. Now is it seen?
yeah now it is seen correct
Okay, sorry about that. I think the connection was a little we had to reconnect. Sorry about that. So this is how the story went of this lady who received 24 ACCENTRIX and 7 ILEAs. So it is to keep coming back, and you can see that, these lesions. So this is how the hyperreflective foci, as we are aware, show activity of the lesion. They are either migrating RP or pigment-laden cells with exudates and fibrin and microglia. So they show activity. So this is how you can see that there are a lot of exudates here, HRFs which are seen here, So after first of the injection, look at the flattening of the PED. It was so dramatic. You can actually see that it's, someone is sitting on it and sort of flattening it down towards the RP. The RP is like coming down. This is at 1 week again. I was so happy, that this has come down. Then this is unfortunately at 3 weeks. Can you see this? Bump has come back again. With the HRFs, all have come now into the subfoveal region, and the vision has again dropped down to 660. So we are aware that as per all the trials, PED was almost present in 50 to 80% of wet AMD patients. And only 25% of the PEDs actually resolve in all these trials, whereas 80% of all the fluids go away. So PED is a very tough nut to crack, which we are very aware of. So we decided to give the second injection, as you will see from this case, because it didn't show the persistent response which we wanted. So this is when we gave the second injection. On day 3 post second injection, her vision again recovered to 618 from 660, and you can see there was a 200 micron reduction in this height. I'm just measuring the height here to the approximate choroid level, which is not very clear. As you will see, as we go ahead, the choroid will getting clearer here, So again, we had a 100 microns further reduction in day 10 post-op, and the vision again improved to, was at 618. So at 5 weeks, when she came back, post second injection, her vision was 612. Now you can see the Crow's approximation of the PED to the choroid here. It's actually the foveal contour is back here. It's not actually flat enough, but totally flat, but it's very, very good compared to what it was before. So again, we decided to extend it and see, because it's still working and the vision is improving, and the PED is flattening. So I'm not necessarily, like giving 3 loading dose to all my patients, except maybe treatment naive, I might give this. This is the next case which I treated, again, a patient receiving previous multiple treatments, a 80-year-old, very nice South Indian lady with an occult CNVM being treated with me from 2003. So we are before the VEGF era. So she's received 2 PDPs and then multiple PRN, ranibizumabs, almost 40 injections. And you'll be surprised why 2 DEX implants, you'll say in AMD. What's DEX doing here, So she presented when at, post like 9 months, like all people are coming after this lockdown with the vision down to 3 meters from 660, which was the always vision she used to maintain, with drill, cyst, SHREM, all the biomarkers of an active net. And we switched over to brolucizumab, discussing with her daughter, who is a teacher in an international school. And 3 days later, I will just share with you all what happened. So this is how the story, fast forward to 2010, how that, CNV keeps coming back with the PED increasing, with intraretinal cysts which are forming, with HRFs are seen here. And this is like a total drill, like normally we talk of drill in diabetes, but this is a drill in AMD, So that is when I switched to Ozurdex, hoping that maybe I'm missing out something. There's an inflammatory element in this lady, of the CNV. So, but frankly, I'll tell you, it didn't move the fluid a micron, okay, with the Ozurdex. So I've moved back to ACCENTRIX, ACCENTRIX is to keep a like, stable. But then see, this is like July 2020 and then no follow-up, as you are aware of this. And this is in November. She lands up in my clinic with a really like a messed up retina. You'll say, what are you treating, Ajay? I mean, there's nothing to treat. There's a dystrophic cyst which is there, a large cyst. There is no retinal architecture there. But then we said, let's try it, So this is 1 week post-injection, okay? So there's again a 200 micron reduction in the height and the inner retinal architecture is sort of regenerating. I don't know from where. And then at 1 month was this surprise. So this lady, as you have seen throughout, she's never flattened, boss. Never. That massive intraretinal cyst, which I was thinking was this, that whether we are dealing with a cystic degeneration of the retina with degenerative IRC, intraretinal cystic degeneration, which is a sort of a dystrophic or degenerative condition because of the RP atrophy. But I was surprised I would have to rechange my diagnosis post PAGENAX to an exudative because it responded to treatment, So the large ovoid cysts had a response, but they were waiting for this new drug, to show us the response. So maybe there is some tachyphylaxis to the older molecules because she received 40 injections and she was waiting for this new molecule which worked differently, So this we move to the next patient. This was again a 79-year-old gentleman who was having a large occult CNVM since 2017. We had done his cataracts and he had a 612 vision when the CNVM started. Again, very sincere patient, multiple injections, almost 30 injections PRN. Then he developed a PED slight rip with a subretinal hemorrhage, which was treated with gas and ranibizumab. We switched to aflibercept also, and then Dex implant again. I'll show you why. And then again, lost to follow-up due to lockdown. Now back with the intraretinal and subretinal fluid. I'll show you all the images. Yeah. So this is how the story starts, just with a serous fluid here. You can see in 2017. Then PEDs coming up. Then further multiple PEDs coming up. Every time we're treating this with the injections. So this is when he came up with a bleed. Yeah. So again, very sincere patient, very closely following up, no complaints at all. And this is how the bleed was there. And then we gave that gas with ranibizumab to him. So he improved, then he used to not improve. Then this is Jan 2020, pre-COVID, okay, you can say. So there's a PED with SHREM, with IRF cysts are there. So then after that, fast forward to this lockdown where all these old people were like, inside their homes, and he came up with this further degenerative sort of cystic fluid with SHREM, with PED, and vision was down to 3 meters. He was never that bad. So there was so much of SHREM there, which is a poor prognosis sign. But the man insisted, let's do something, This is how the fundus photo looked like, So there's a scarred CNVM with the old hemorrhage here. And this is the flattening observed at 1 week. Yeah. So all the intraretinal fluid has gone. SHREM is beginning to come down, hunker down, the elevation has gone down. And at 1 week again, vision came back. So what I'm going to show you all in these cases, I was not expecting it, but vision has moved parallel to the anatomical structural improvement in all these visions, Even in these chronically bad cases, which we all have a subset of these patients in our practice, So this is at 1 month, You can see that, the actual somewhat fovea, you don't have to imagine where it is, but it's seen there. And the lesion almost looks bone dry, except for this, PED here, a pointed PED. And I'm again extending his treatment. So I'm not giving him further because there's no fluid coming back. So there's no logic in injecting a dry macula is what I feel, in these patients who are following up religiously, monthly, from both the point of view of seeing for brolucizumab, how it's effective and how we are looking at any side effects. So we keep our hawk eyes open of Hawk and Harrier. So I'll just end with one of these last cases, a 80-year-old male with a right eye and a left eye CNVM. He had both eyes, So we had treated him. So the right eye had scarred down to 2 meters and the left eye was a good eye. So the right eye, we had treated him with multiple bevacizumab, and the left eye, he received aflibercept and ranibizumab because the patients always shift to a better molecule when the second precious eye is affected. So we decided to do brolucizumab for him, and this is how it was. Yeah, so this is the right eye PED. You can see how it starts, and then it scars down. You know, the right eye. This is the left eye. In December, when we treated him for this double hump camel-shaped PED humps, which are there here, and this is the ICG which we had. So the right eye shows a scarred CNVM, and the left eye shows a hot spot with an PED here, showing a sort of dark area there. And this is at 1 week. You can see there's an almost reduction of 200 microns again, is what I've seen. You know, at 1 week, most of the fluid, wherever, whichever compartment it is, it just reduces by 200 microns, and the foveal dip has come back, you know. So the two humps have actually flattened down tremendously. This is the high definition raster scan through the lesion. This is my last patient. Again, an 80-year-old lady, right eye, occult CNVM, a conical PED, 80 ranibizumabs over 10 years. Because as you're aware, PEDs don't, flatten. And the left eye was a scarred CNVM. So post-lockdown, again, vision dropped to 616, both eyes. The lady came back running when the lockdown was opened. And then we moved her to brolucizumab. So this is how the story starts, you know, as you can see here. There's that, you know, PED which flattens, then this PED comes back, fluid comes back. This conical PED here, as you can see, which is like tenting up the retina, but it flattens out every time with plain aflibercept. So she is coming back to me every time she can't read, you know, because that's a good eye, which she reads her religious books. So every time there's an element of pachychoroid here, which we can see here. So right eye conical PED, SRF with a pachychoroid there. And this is the right eye when post-lockdown she came after 9 months with now intraretinal cystic fluid is there. This large IRFs is there with SHREM and this multi-layered sub-RP sort of lines which are seen, scarring lines which are seen post-injections, multiple injections. So we did brolucizumab, yeah. And this is the left eye. I just want to interrupt with that also. There was a recurrent of a temporal to the scarred. There was a PED which came up, you know, in this eye also after the 9 months of this. So post brolucizumab, day 1, she didn't move a bit. The IRF just stayed the way it was because I think it was so chronic. But at day 15, this is the OCT. I mean, I don't have to say anything, like, you know, even everything's looking quiet, flat, no fluid, not a drop anywhere, you know. And vision also came back to 624. So, you know, at 1 week it wasn't there, but at 15 days it came back, you know. So, and even the left eye, you can see that the PED has gone in the scarred eye, you know. So just end with a couple of slides, then we can go into discussion, is that, you know, it's associated with a greater and a sustained reduction of SHREM and PED, this drug. And there's complete drying of most compartments, even the sub-RP, surprisingly, in this, you know. And there's maximum reduction of SHREM, which I've seen. And the safety review, which Ajay was speaking about, you know, in post-Hoc and Harrier analysis of almost 1,800 eyes, they found that, you know, the loss of vision was hardly, you know, in 0.74%. Moderate vision loss is 15 letters loss on ETDRS. So, you know, though you might have IOIs and vasculitis, but the vision losses percentage is very, very low, you know. And the IOI first event comes within the 3 months of the first injection. That's why we are following up all our patients, you know, at monthly intervals, you know, to see for the effect and the side effect both, you know. This was the AO 2020, IRS registry, which they did of 1,200 patients. And they said that the risk of, you know, IOI was highest in 6 months, you know, if a patient has prior IOI, to develop post-injection IOI. So the overall risk of retinal vascular occlusion or retinal vasculitis is 0.4, which increases to 4% if there is prior IOI or RO within the last 3 to 6 months in that patient. So I think if we exclude this subset of patients, we'll be very happy, and our patients also will be very happy. So this is my last slide. So 50% of wet AMD patients have unresolved fluid as per all trials. 1/3 need monthly injections. So we had an unmet need in this wet AMD, you know, slot which was there of these patients. And why do these patients develop IOI and retinal vasculitis? is maybe that, one theory which the has been given to us is that there is something like treatment emergent or boosted / induced anti-drug antibodies, ADAs, which are there. So there's a greater and a sustained reduction in PED, as you saw in my patients, and of SHREM. And this is a very small molecule, so maybe it penetrates better and has a very rapid clearance and more active binding. So thank you very much for your patient hearing. Thanks so much. Yeah.
Thanks, Ajay. Thank you so much. I think we've had a good presentation. So I think most of us, I think the main question that is in our mind is when we start, when we make a decision of injecting brolucizumab, what all examinations you will do in a patient to decide that, okay, this patient is right, and how will you tell the patient about the problems that could come up while using brolucizumab as compared to the other anti-VEGFs which we have been used to. Maybe Anirudh could say that, because that's the one thing which is really troubling all of us. Otherwise, this molecule is definitely magical. It gives beautiful results by all the presentations which you've made. So I would like each one of you to tell how did you approach your first patient, and what all you look for, and what was your follow-up schedule to rule out any intraocular inflammation happening post-injection?
Yeah, I think I have already discussed the first patient. The plan was that I will start this new molecule in a refractory case, but it didn't happen like that. This gentleman actually opted for this brolucizumab molecule. Yes, I was really apprehensive in the post-op. In fact, that was the time when Dr. Rajanarayan reported an inflammation following PAGENAX. So I was actually seeing this patient very frequently. The next day I saw this patient and there was phone calls, but luckily nothing happened. But definitely this Dr. Raja's case also, that was a post-cataract patient, I think 7 days post-cataract. So the main important thing is you need to rule out any inflammatory component. If we see any sort of inflammation, we should avoid this molecule. Otherwise, I think this side effect is there definitely, but if you see the percentage, I think the 15 cases out of 10,000 injections got some sort of vasculitis, and only 5 out of this 10,000 injections had a dip in the vision. So it is pretty low. Definitely, this component is there, and it is there with any other anti-VEGF molecule. I think this vasculitis, we are overseeing it. And if you see 1,000 injections which has been performed in India, apart from one case, there is no reported case of vasculitis. So that is a positive thing we should see. And we are actually seeing this patient. Not a single patient of mine had any sort of inflammation.
Sir, I have a question for you, Anirudh sir.
Yeah.
I'm Dr. Anubhav from Eye Care Hospital, Noida. Good evening, sir.
Good evening.
Sir, I just want to ask whether the consent has any change, especially for PAGENAX as compared to other anti-VEGF consent. Do you use the same consent form, or you have changed the consent form?
The same consent form. And if you see the initially this inflammation component was there with any other anti-VEGF, and including the biosimilars. So nothing different with this new molecule.
But I think you will have to add to that because when we made the consent form for AOS, I was involved with that consent form for Avastin. There is no mention about an occlusive vasculitis there. So I think that occlusive vasculitis will probably have to be mentioned.
Sir,
Right.
I have given around 7 injections so far, and I have also generated a new consent. Basically, even if we see that AIOS consents also, if you go through the Lucentis consent also, they have probably not seen towards the last part of the consent I have mentioned about Avastin rather than Lucentis in that consent, if you go through the consent carefully. So I have modified the consent and I have put specifically about the chances of inflammation in these cases. And I regularly explain my patients that the risk of inflammation is almost 4 times that of the other injections. But then it is a wonderful drug, which I have noted too. I didn't have any complication yet with any of my patients, and all of them are doing pretty good. In fact, out of 4, there is only 1 patient who is treatment naive right now, and there are 3 who are, had been treated earlier with ACCENTRIX and are doing fairly good, I would say.
I think we should, apart from the consent form, this all patient of mine I had actually mentioned about this inflammation. In fact, one of my he is also in medico, refused to take PAGENAX, rather opted for aflibercept, going through the literature. So obviously, this initially we should always do a verbal discussion with the patient and let the patient.
I feel while mentioning in the consent, we should have a general consensus consent,
Right.
or an approved consent instead of individualizing the consent. It should be in a proper format, because this is a legal thing. Which, if anything happened to even a single patient in your practice.
I think Anubhav, VLSI should probably be coming
Yes,
out
sir.
with a consent, but before that happens, I think each one of us has to mention to the patient of what is actually being discussed globally about pralicizumab. What I
But
would like to
verbally
ask-
informing the patient will be a good option, sir, because whatever is not written is not legal.
I agree with you. I agree with you. That means we should probably write down everything possible, what can happen, and explain to the patient, and then go ahead and use it.
Even if you are using the general anti-VEGF consent, Anubhav, I suggest you there are columns in which you can write specific about the drug also.
Yeah.
ठीक है, sir.
You can write that. The other thing which I want to mention is when you're examining a patient post-injection, what all things you're looking for. This is for everybody to understand so that you don't miss out any information.
I think we should see the anterior segment. Other than posterior segment, we will always be examining the anterior segment. Also, we should examine an intraocular pressure, which we do in all our anti-VEGF patients. But this is, as this molecule is new, we do it a little bit frequent. Other than like in the COVID times, we were actually not calling the ACCENTRIX patient the next day. But for the PAGENAX patient, definitely the first week visit was mandatory, and phone calls were made to make sure that he's fine.
The whatever literature is available, PAGENAX inflammatory response, which is immune mediated, usually does not happen after the first injection. It usually happens later on. So
It can happen with the second and third injection as well.
Yeah. Because it's a type 3 and type 4 immune mediated response, which is what is important. So, have you ever thought of injecting a steroid with the PAGENAX while injecting?
Not yet.
No,
I think we were in some webinar. Somebody actually injected an Dex, not dexamethasone injection along with the PAGENAX, but I didn't do it myself.
No, this is my plan actually.
No, what am I doing? No, most of my patients post-op regimen, we give them antibiotic drops. So I usually add a Nevanac or a NSAID and a topical steroids to my patients. So I actually do it for most of my anti-VEGF patients who are diabetics, because that they have an element of CME with CSME. So we feel definitely these two drugs will, act synergistically with the anti-VEGF. So that's what I'm following. My patients are receiving topical antibiotics, NSAIDs, and topical steroids. Tretfort is what they're receiving.
So, anybody has any other questions before we move on to the case discussions? And I would request Anirudh and Ajay to stay back. Anybody wants to ask them any questions, or should we move ahead?
No, I was just asking, what is the cost? Cost, is there any difference in the cost of PAGENAX?
Slightly higher than ACCENTRIX.
It's not very costly, sir. It is not much as much as ILEA. That's why the ILEA company is now trying to, reduce the price to, make it competitive. It is a very attractive price as for the
really
drug.
attractive. Yeah, compared to what is available
Okay.
in the West.
Okay.
Yeah, so I would request Professor Goel and Dr. Atul Singh, who are chairing the next session, to start the proceedings of case discussion, sir.
Okay. Dr. Atul?
He even if he does, he may not be around, logged in, because he was having some problem. So आप start कर लें. We are all here, so don't worry.
You may just call the first speaker. I think
first
we can.
Anshul is
Anshul.
presenting the first case of on intrascleral haptic fixation of a dislocated eye. So
Okay.
the plan for this is 5 minutes of presentation and 5 minutes of discussion. So we will keep the presentation time same. We'll probably reduce the discussion to 4 minutes because we have about 45, 46. We can go beyond 9 o'clock a little bit, but I think let's stick to time. Anshu can.
Dr. Anshul.
Anshu, you are muted. Can you unmute yourself? Anshu, you are muted. Anshu, you are muted. Sunil, can you unmute Anshu?
I'm trying. He's just muted.
Can you hear me now, sir?
Yeah, we can hear you now. You are muted earlier. Right.
Can you see my screen?
We can. Please put it on the on the slide.
All right, so I'm going to talk about the intrascleral haptic fixation of a dislocated eye, just a small surgical technique presentation. Basically, eye dislocations has been reported at a rate of about 0.2 to almost 3%, and it may occur early within 3 months, or it is a late complication of cataract surgery. Prior vitreoretinal surgery or a trauma can precipitate that, or an inherent pathological process such as pseudoexfoliation or a connective tissue disorder contribute to the lens zonular weakness and the dislocation of the IOL. So for a VR surgeon, variety is the spice of life, and we see all these kind of IOL situations in our life, which makes us, treat these patients in different challenging ways. So the technique which I'm going to talk about is about the simultaneous rescue and intrascleral tunnel fixation of a dislocated 3-piece IOL. It is least invasive to avoid excessive manipulation, to manage the same IOL in a normal position, and you can trade between 3 to 5 sclerotomies based on the techniques being used. The IOL haptic can be secured using a scleral tunnel or cauterizing the haptic as in a Yamane technique. So this is a small video which I have put. In this video, this is the patient, a 60-year-old lady who came with dislocation of the IOL in the vitreous cavity. You can see that there was fairly good, capsular material there, but not adequate support probably, which has led to the dislocation of the IOL. So first we mark the 180-degree opposite points, 2 millimeter from the limbus, and then we create a small tunnel juxtaposing the markings using an 18-gauge needle. With this, we make an entry, a 23-gauge entry in the vitreous cavity. Following this, the removal of the capsular fragments and the lenticular matter was done, and a complete vitrectomy was done. Then the pre-marked sites are now used to form the 23 gauge entry points, or you can call it an exit point for the haptics. And then the IOL is lifted and the haptics are now exteriorized using the handshake technique. So individually, each haptic is held at the tip and they are brought out. Usually the second haptic is more difficult to manipulate and bring out, keeping an eye on the other haptic. And then the haptics were tucked in the pocket. This leaves the IOL well centered and quite stable. A partial FG is usually I do in all these cases because that helps in better centralization and the centralization of the IOL. Sorry, 1 second. So it is usually advisable for all anterior segment to put a 3-piece IOL in the sulcus in case of any doubt with the integrity of the capsule. And if you run into a problem, there's no shame or fault in cleaning up the vitreous and closing the incision, and either referring it to another surgeon, or you can call back patient, and in the meantime, you can yourself, if you are trained to do it, you can yourself do a secondary IOL with these simple methods. The advantages of a scleral haptic fixation is it has less pseudophacodenesis, less UGH syndrome, no suture-related complications, and no tilt due to stabilization of the axial position through externalization of the most of the haptic. The IOLs which I prefer is most of the IOLs which I've used is the Sensor, which is from Johnson & Johnson, which has a PMMA haptic. But in literature, they say for Yamane technique, you can use CT Lucia, a Zeiss IOL, which has a polyvinyl fluoride haptic, which is helpful when we kind of cauterize these, we need to cauterize these haptics. Thank you all.
Thank you, Anshul. It was a nice presentation. And
thank you, sir.
Anshu? Yeah.
Yes, sir.
I have a question for you, Anshu, is that when you have haptics which you brought out, what is the length of the tunnel within the sclera for which they travel, and do you cauterize the end of the haptic tips as is done with the Yamane so that it becomes a little bulbous so that it doesn't go back?
This wasn't a Yamane, sir. I do Yamane, but this wasn't a Yamane. It was just the exteriorization of the haptic and just burying it in the tunnel. In Yamane, we do cauterize the haptic. This was a kind of straight entry, sir. If you have noticed, this is not a slanted entry which we do in Yamane. It is a straight entry for which I prefer to do in these kind of scleral fixations.
So it comes out straight and then it goes into the tunnel.
Yes, sir.
Okay.
Because there is a curvature of the haptic and there is the haptic is malleable, so it goes in that way.
And there's no risk of it going back?
Not really, sir.
Okay.
Because it is tucked in the tunnels, it keeps the haptic well in place.
So I had done like this, but I was so scared that I sutured it.
Oh no!
I'll be frank with you that
I have actually reduced the number of entries by using trocar, our usually vitrectomy port at 3 and 9 position, and use these exit points as vitrectomy points earlier. Exteriorize the haptic through the trocars and then gently remove the trocars to take the haptic, keep the haptics out in place.
I have done many cases such like sir, and the stabilization is quite good in such cases. So if you are well placed, if the haptics are well placed in tunnel, then stabilization is quite good.
Right.
how far is the tunnel entry from the exit port? What is the
Pardon me?
What distance do you keep between the scleral tunnel entry and the exit port of the haptic? You keep some distance
Approximately 1 millimeter or 2.
to make it easier to put inside the tunnel, because I've had
Yes,
a lot of times
because
very close.
sometimes what you'll land up with, you can actually retract the haptic back slightly and then pull it towards the tunnel. The only thing which I would say is make your, the tunnels which you have in sclera, they should be very much visible, because you should not be struggling in the end. Sometimes what I do is I mark the entry point of my tunnels with a blue dye.
A small modification which has been, I tried it once, has been actually has been suggested by Sangeet, where you enter with a needle from just beyond where the entry point of the tunnel is going to be. You bring out the needle, so your needle in the tunnel works as a tracking railroad method in which your haptic slides in.
Right. That is also possible. There are people who have actually brought out the haptic and kind of reinserted back in the cavity to stabilize the IOL. There are reports of that also. There are different ways. There are 100 of people, 100 of ways to do it.
Yeah. One thing which I would suggest is, which I actually burnt my fingers on this, is to a single piece IOL, which I was not, we wanted to put the same IOL. We sutured the single piece IOL just like a sutured SF IOL. But what happens is that single piece IOL, when you suture it up, it actually becomes a little twisted. So the patient had some astigmatism. I do not know how, but over the period of follow-up for about 4 to 5 months, that astigmatism became better and the patient was stable. But it was very traumatic for the few months that every time patient comes, the IOL is nicely placed, but the IOL is a little bit tilted with causing astigmatism.
Right.
So any more questions?
I think even if the IOL is tilted within the vitreous or within the in the posterior segment, it does not make much difference in the optics. Actually, the vision is not much affected by the tilting of the IOL within the vitreous cavity, because the refractive index in front and behind is almost same. So the deviation of the rays of light is not much.
Sir, if they say, they have done studies, if they say if the IOL tilt is more than 10 degrees, it does cause astigmatism. It does cause, sir.
It causes astigmatism, but with correction, the vision is almost the same.
Yes, sir, that is true.
So there your ego gets hurt, sir.
So should we go to the next one?
The next presentation.
So
I think with
next is Dr. Prashant Jain or Dr. Anubhav?
Next is Anubhav, sir. Anubhav is presenting my experience in ROP.
Okay, Anubhav. Dr. Anubhav. Please.
Okay, sir. Good evening, sir. I'll just share my slide. Am I visible, sir?
Yeah. Make it slideshow, Anubhav.
Yes, sir.
Yeah. And just to tell you that we have over 100 people who are actually viewing the presentations at the moment.
Yeah. So, good evening, all. So, I'm sharing my experience in retinopathy of prematurity. Just a brief about ROP. It's a vasoproliferative disorder of premature babies' retina. Recent Indian screening guidelines given by RBSK says that all infants below than 2,000 grams and below than 36 weeks of gestation should be screened for ROP. With the increased use of advanced neonatal care and increased premature survival rate, ROP chances are increasing day by day. So I'll be directly sharing my my experience in 2 cases of ROP. First case is of a premature baby boy who has a gestational age of 29 weeks at birth, and birth weight was 870 grams. I saw that baby after 4 weeks, that is 32 weeks, and that time the weight was 1070 grams. Baby was having anemia, multiple blood transfusion was done, was on ventilator, and a lot of systemic issues. So this was a picture of the baby. This is, I'm showing one eye. Picture was same in both the eyes. So you can see dilated tortuous veins, and there was complete absence of vessels just outside the zone 1. And this is a picture showing complete avascular area. We initially injected this, we made a diagnosis of rush disease since there was no typical threshold disease features like staging seen in this case, and there's abrupt stopping of vessels immediately after the vascularized zone 1. So we made a diagnosis of APROP or rush disease, and initially we injected the baby in both eyes with injection ACCENTRIX, and immediately after 3 days of ACCENTRIX, the vessel normalized. Whole tortuosity and dilatation is gone. But unfortunately, there was recurrence. After 3 weeks of injection, you can see stage 2 with avascular retina, and we lasered the baby after that. So baby did well after that. The second case, it was a premature baby with gestational age of 31 weeks and birth weight was 1,100 grams. After 1 month, I saw the baby. Baby was 35 weeks with a weight of 1,320 grams. Again, fundus picture was showing dilated tortuous vessels with stage 3. You can see vasoproliferative lesions in the vitreous. It was in the temporal area. It is in the inferior temporal area, and you can see easily ora serrata showing the whole area of avascular retina. So since it was in the zone 2 to 3, it was in the posterior zone 2 to 3 threshold ROP. So I directly lasered this baby, and after probably 2 weeks, this whole plus disease has gone, and the retina was showing very good scarring. So according to ETROP, type 1 ROP was classified as high risk pre-threshold ROP, and which needs immediate treatment. Low risk pre-threshold ROP needs just observation. There are various landmark trials which have shown that there is significant anatomical improvement after various treatment. Cryo ROP has shown improvement in ROP treatment after cryotherapy, but the unfavorable anatomical outcomes are very high in this cryo ROP group. So ETROP was another landmark trial which shows effectivity of laser treatment in ROP and shows significant reduction in anatomical unfavorable outcomes from 27 to 19%. But and after that, BEAT ROP came, which shows the importance of anti-VEGF in ROP. And after this study, whole understanding for ROP treatment has changed. The treatment came from cryo to laser, then injection started, and the picture has changed. The unfavorable outcomes has decreased from 27% to 4% after the injection introduction in the picture. This study also shows that zone 1 ROP responds well with anti-VEGF, but zone 2 ROP fortunately responds well with laser treatment instead of anti-VEGF. There were more recurrences seen in zone 1 if we did laser, but if we did laser in zone 2, the recurrences were less and the results were good. This also shows, this study, BEAT ROP also shows that after injection alone, recurrences can be seen as late as 1 year. So we need very good follow-up of the baby, which might be tiring for a treating surgeon and the premature baby and parents all. And anti-VEGF treatment and laser treatment, both are very good. Instead, giving anti-VEGF is very comfortable, but laser is still the gold standard treatment. And most of the surgeons, most of the doctors now prefer anti-VEGF injection followed by rescue laser after 2 to 3 weeks once the zone 1 vascularizes, which I also follows. So this is the picture of RETCAM, which I am showing how to give the laser in a ROP retina. This is a stage 2 and plus disease. You can see whole avascular retina after this. So this whole area has to be lasered till the ora serrata. This picture showing how the laser has to be given and how the buns has to be placed. So this is picture showing good, significant good resolution of ROP after the significant good treatment. This is the smartphone imaging which I innovated just for the convenience sake, and which has simplified my screening and explanation to the parents massively. So you can see how I have used 20 diopter lens and 28 diopter and 40 diopter lens, which is giving a very good comparable images as compared to Trinetra and Opto's view. So why to screen ROP? Premature babies are never born with ROP, but they 50% babies may develop ROP, which in 50, which might resolve spontaneously, but in only 50%. Rest might have only 5 to 8% might have worsening, which might need immediate intervention, like in terms of laser or injection. On very few of them, if they land up into treatment failure or they land up into stage 4 or 5, they might go blind for their life, which is really troublesome for the whole family. So if you give timely treatment and good treatment, babies might have very good vision for lifelong. These are few of the articles which can be, you can get benefit with the smartphone imaging, and it's a simplified way of ROP screening in your clinic. So thank you.
Thanks, Anubhav, for a good presentation. Any questions?
Dr. Anubhav, I would like to ask you whether you have ever given a re-injection in such cases, specifically in zone 1 APROP, where vascularization has not happened and there has been a little reactivation. Do you consider that?
Usually, if the baby is stabilizing, after one injection, zone 1 get vascularized. And once the zone 1 get vascularized, I usually don't repeat injection. I have more concern about zone 1. Once it is vascularized, I can give laser, and mostly I'm doing that. I have not given second injection till now in my clinical experience.
Okay. Even in small zone, half zone ROP, half zone APROP, where there's very small vascularization to begin with, which actually, I mean, there are certain cases where it is still very difficult to laser because even after one injection, macula is still not perfused. Have you ever encountered such cases? And
I have not encountered such massive cases. Might be, I have very friends in PGI, they can explain you better, but I have not experienced that 1/4 zone ROP or half zone ROP cases that badly. I have seen few cases of half zone ROP, but they have done well. And zone 1 has vascularized. I have lasered the babies, but I've never given second injection.
Okay. Ruchir, I have actually done 2 injections. I'm usually doing ACCENTRIX in most of my patients. I'm not doing Avastin, So as per Rainbow trial, the ACCENTRIX effect wanes by around, 1.5 months. And if in these babies, if they are still very small and, super premature, you cannot laser them because the media is not clear or anything, or for whatever reasons, the systemic condition of the child, then I've had to inject, repeat injection at about 1.5, 2 months in a couple of these babies only. But otherwise, I usually try to catch them and laser them, as Dr. Anubhav said. I think that's the best combination therapy, But then when I was speaking to Mrs. Mintz Hittner, who did that BEAT ROP trial, she said, why you're doing 2 things which will create different 2 complications, because initially we were worried about the anti-VEGF side effect. Then laser, we all know, induces myopia, So she had a different thing of doing only a monotherapy, So I think it's still evolving. I think we are not very sure what is the correct way, is what
So if you give in ACCENTRIX, ranibizumab recurrence is much earlier. Bevacizumab recurrence is much late. What I've seen is what you told is correct. 1 to 1.5 months, ranibizumab will show recurrence. But Avastin will show recurrence after 2 to 3 months. By that time, obviously, zone 1 will get vascularized. So if we are experiencing half zone or quarter zone ROP, I feel Avastin will work better than ranibizumab.
The only problem is that if you give more than 1 injections, how long are you going to follow up these patients?
True, sir.
Yeah, but Ajay, then you laser them, whenever it's possible. The second injection my subset had, because I couldn't laser them, for whatever reasons, either the systemic condition or the, media wasn't clear enough, But if you can laser them after the first injection, as Dr. Anubhav said, then you don't require the second injection.
So the take home should be a combination of both.
Yes. Totally.
And sir, one more thing I just want to add. I have experienced that the worsening after injection is very fast and earlier as compared to normal worsening.
Yes. Totally agreed.
If you skip the baby for a week after recurrences injection, you might land up into advanced stage immediately.
Yeah, it's like a rebound phenomena. Yes.
Yeah, it's like a rebound phenomena. So better to sleep well instead of a nightmare.
Yeah. Laser them whenever the first chance. Yeah. Totally agreed.
So should we go to the next presentation?
Yeah.
Any other questions? Prashant, I think she's going to talk about surprises and multimodal imaging.
Yes.
You can share your screen, Prashant.
Yes, sir. I'm sharing. Just 1 second. Able to see the screen, sir?
Yeah.
Good evening, all. I'm presenting one case of 57-year-old male who complained with diminution of vision in left eye for 1 month, and is a known case of hypertension. visual acuity was best corrected in right eye was 6.6 and in left eye it was 6.36. So on fundus examination, right eye we can see few RPO alteration. Apart from that, everything was fine. In left eye, we can see a big area of SRF. And then we did OCT. Few RPO alteration was there in the right eye, along with few Pecchi vessels. In left eye, we can see SRF with PED. This huge SRF in the down sections. And few Pecchi vessels we are able to see in left eye also. So we did angiography, right eye was pretty okay. Left eye, we can see smokestack pattern. And when we took OCT from there, we can see PED with SRF. So what's new in this case? But in all the pachychoroid cases, we used to do, or I generally used to do ICG also. And in this case, we can see a few dilated vessels in the right eye, choroidal vessels. But in left eye, when we did ICG in this case, we can see hypocyanosis corresponding to PED. And at the edge of the PED, we can see beautifully, we can see 3 polyps are there. At hot spots, we can see in the late phases also. So when we did multimodal imaging, we did eye tracking on this polyp. We can see PED, we can see thumb-like PED, we can see TLP along with DLS. And in this section, we can see the DLS along with thumb-like polyp. So through this case, just I want to clarify the importance of multimodal imaging. We have to see each and every section on OCT. Like we can see nosed PED in this case in few of the section. We can see thumb-like PED, even DLS on the OCT we can see. So it gives us a fair idea that we have to proceed with ICG as well as FFA in such cases. And while we are doing FFA, we can see smokestack pattern, but ICG has completely changed the scenario, and we can see that beautiful polyps are there, and straight away the diagnosis is PCV. So take home message is importance of multimodal imaging, and ICG should be done, at least I am doing in all my pachychoroid cases. And SD-OCT, we have to see each and every section carefully. So it was a small presentation. Thank you.
Now, Prashant, I want to know what happened to the patient. What did you treat him with after this? And what was the follow-up?
1 second, sir. Just 1 second. Sir, straight away, I started with Eylea injection in these cases. Generally, if PCV is there, I'm starting with Eylea 3 loading doses.
I think this is the ideal case demonstrating the pachychoroid spectrum.
Yeah. So what happened now to this patient? I want to know.
This patient, sir, this polyp has regressed. We have done ICG after 3 months. This polyp has regressed. Generally, in such cases, if polyp is not regressing, unfortunately, now combined PTT is not available. But I used to do combined PTT in such cases. The result is beautiful after combined PTT. But right now we don't have option of combined PTT. So I am always following this patient with Eylea. If they are not responding to Eylea, I don't have any option. We are repeating the Eylea only.
So he became 6/6 and the PED and the fluid went off with the first injection, second or the third. I want to know. That's what I want to know.
Second. First injection, SRA was there, gone. That slight flattening of PED was there, but in the subsequent injection, complete flattening of PED was not there. But yeah, this complete resolution of fluid was there. Okay. If extrafoveal or extrafoveal polyps are there, definitely we can laser it off on the first setting itself.
Very good, very good.
I think what important Prashant has conveyed is that multimodal imaging has changed the diagnosis from CSR to a diagnosis of, there is a PCV. So that should not be missed. And maybe, when you don't have an ICG, I think Octa can also help you a lot.
Yeah, definitely.
Especially, sir, adult onset CSR should be screened for PCV, pachychoroid spectrum, by doing ICG.
True.
I think Ajay sir, you all can actually help this marketing. This PDT is not there. It's not with Novartis, but some company who has taken actually is not marketing in India. It's in few cases they were really helpful. The PDT.
Definitely.
I think we should get into the VRSI platform and let them do it. I think we should request Raja, through VRSI. That'll be the best way to do it, I think.
And also sometimes, long time back when we used to do PDT, some patients used to stabilize after PDT when they never used to stabilize earlier with the injection.
True.
And with the chronic CSR as well.
No,
Yeah,
and even in AMD, there's a change.
There I'll do a micropulse.
Yeah, you'll do micropulse.
There's a lot of debate, PDT versus micropulse.
Not to be discussed there. So I think no question, we'll go to Ruchi's presentation of a large macular learning for a young surgeon. Ruchi is a young dynamic vitreoretina surgeon who is trained at RPC and is doing extremely well.
Thank you.
Yeah, Ruchi,
Yeah.
you can share your...
Good evening, everyone. First of all,
Can you increase your volume, Ruchi?
Sir, am I audible?
Yeah, you're audible, but thoda sa uncha bolo.
Okay, sir. Good evening, everyone. First of all, I would like to thank Ajay sir for giving me this opportunity to talk about my work. So I will start. So I don't have any financial disclosure in this presentation. So the case is a 26-year-old male who presented with a history of blunt trauma to the left eye 2 years back. He had a sudden diminution of vision with minimal visual recovery. He had already been diagnosed as a case of a large post-traumatic macular hole outside, but because of poor prognosis, he had not been operated upon. So on clinical examination, the right eye was absolutely normal. BCVA was 6.6 Nellens and left eye had 2/60 vision. There was RAPD present in the left eye. Patient had an inferotemporal iridodialysis, and on fundus examination, there was a large macular hole with pigmentary changes around the macular region. So this is a clinical picture of the anterior segment showing the iridodialysis. And this is a fundus photograph showing a large macular hole, and superior to the macular hole, there are old pigmentary changes that are also visible. This was the OCT of the patient. It's more like a flat macular hole. The base size was 1.6 millimeters and the hole size was 1.08 millimeters. So I had done such cases before, and I used to do inverted ILM flaps in these cases, and the hole would close. However, during this time, there was a discussion going on in one of our WhatsApp groups about a new technique of a large temporal flap, a single large temporal flap, where a senior colleague of mine had shown her results, and they seemed to be very encouraging. So she had shown these she had shared these OCT images where there was a flap closure first. The hole would seem to be open, but the flap would be closing the hole, and over time, 1 to 2 months later, the macular hole would close. So I thought that I could also try the same technique in this case. So I changed my plan to a large temporal flap. Although my senior told me that she only does a fluid air exchange in such cases without any gas tamponade, I still went ahead with sulfur hexafluoride tamponade. So this is a short surgical video demonstrating the technique. Usually in such cases, when I have to get flaps from all sides, I usually peel small strips of ILM so that I can get hold of the flap in toto. So in this case also, I tried to get as large a flap as I could from the temporal side, gently peeling the flap away, making sure not to break the flap in between. So once the flap was there ready, a temporal flap was ready from all sides, I performed a fluid air exchange. You can see the flap moving about while the fluid is being aspirated. So again, I repositioned the flap on the nasal side and completed the fluid air exchange. And I also tried to dry the macular area as much as possible using a soft tip. This was a short video that I had seen, so I tried to replicate the same. And at the end of the surgery, we can see that the hole is very much covered with the flap. So at this point, I injected sulfur hexafluoride, and I was pretty happy with myself that I could do this technique. But when the patient came back after a week, what I realized was that the hole was still open. Nothing had changed, and the flap, as you can see, is visible. It had rotated back towards the temporal side, and the flap is there on the temporal side itself. I still waited for another week for things to change, but again, nothing happened, and the flap again can be seen over the temporal side. So the size of the hole was same, and the base also diameter was the same. So nothing had changed. So at this time, I wanted to see what had happened with the flap. So I did a vertical scan from the nasal to the temporal side, where the flap is beautifully seen dangling at the edge and all over the temporal side. There's nothing left on the nasal side. So I reverted back to my original technique, which was inverted ILM flap. And this time I thought that I will put C3F8 as the tamponade agent. So this is a short clip of the same, where the first step was to engage at the edge of the temporal flap. Then I tried to raise flap from all sides. So flaps have now been raised from all sides, and after that I did a little extending the eyelid peel over the nasal side. So at this stage, I trimmed the flaps a little bit, did a fluid air exchange. And I put C3F8 as the tamponade agent in this case. So this was the COVID time, and the patient disappeared. He did not turn up for the next 9 months, so I had no clue as to what had happened with the patient. To my surprise, when the patient came back, he seemed happy. When I saw the fundus, the hole had completely closed. It is a type 1 closure with the flaps sealing the macular hole area very well. So this is the pre-op and the post-op. The vision had also improved 2 lines. This was the time when I actually went back to the original article which had described the temporal flap. So this same article, the article was, the technique has been described by Micheluska et al., who were the ones who described the inverted ILM flap technique. So what they found was that a temporal flap actually helps in closing the hole. It is equally good with lesser areas of DONFL. They also showed, they have very beautifully described how the hole closes, that first there is a flap closure, and over a period of time, which could range from 1 to 3 months, the hole will close with equal anatomical and functional outcome as compared to a normal inverted flap technique. However, when I read the entire article, I realized that they did describe that in 3 cases, in both the groups, they had a failure, where the flap, where the hole did not close, and surgical failure in their series did not correlate either with the size of the macular hole or any other factor that they could analyze. And in their series, when they did the surgery again, they actually put oil instead of gas that I had done. So maybe I was a little lucky in that regard. So what I learned from this case was that a case selection was probably not right for me. As a first case, I should not have taken a very large macular hole for this technique. I did not do proper research. I heard from someone that a new technique is there, which is very good. And I jumped to try it out on my patient rather than, try it on simpler cases first and then trying it out on more complex cases. You have to be ready for the fallout. It was very difficult for me to explain to a patient why the hole did not close. He had already been told by 3 different surgeons that the hole will not close. And I had somewhat assured him that, that I'll try my best, it might close. And in the end, you should always have a backup plan. So I think the inverted regular ILM flap technique is very good. I don't have any problems with that. And that was the backup plan which helped me out in the end. So thank you everyone for listening.
Thank you, Ruchir. It was an excellent presentation and beautiful videos. Very good. Very good.
Ruchir, can you
And
answer?
Dr.
If anyone
Ajay?
has any questions for Ruchir?
I would say that you have left a very good message also, that you've been very honest with the patient. You know, that is the most important part, and honest with yourself, and you never lost it, and you went back again to try it again. That's good. One thing. Second thing is, you know, about the selection of case. I would definitely say you chose a right case, because you know it wasn't a bad selection for you to take up a case for a new method to be tried, because you know, the patient already had RAPD, had less chances of closure. So you put your best foot forward. You have put your best foot forward, and that's very good. I appreciate your efforts.
And I think, Ruchi, the most important thing is you decided to redo the patient early on in time.
Yes, sir. I operated actually after 2 weeks only.
Yeah, that's very important. Otherwise, you won't have been able to achieve this. And I am actually sharing my video, which is again on macula hole, large macula hole. And probably it'll answer some of your questions, because the Navarroki group, I have read their papers and their temporal flap, but we have described the cabbage technique, which is basically a multi-flap technique. And maybe we can have questions with that later on, or if somebody wants to ask, which
Yes, I want to add one thing, sir. Just one thing.
Yeah.
Peeling ILM till the whole edge is very important. You have to peel ILM till the whole edge very carefully. You should not disengage from the flap, from the whole edge. And then even if you put single temporal flap, or you put like cauliflower thing, it will close even 1700 microns large hole very easily. You need not to do anything extra.
True.
That is my personal experience in a lot of large macula hole cases, even traumatic large macula holes.
Close with converted island. But anyway, so I'll just share my thing. Can you see my slides?
Sally, can you stop share for a minute?
Okay.
First open the presentation, then do the slide shows.
Okay. Is it visible?
Yeah.
Okay.
Now it is visible.
Okay, so basically a large macula hole for cabbage technique. So this is so this was a patient who was 61 years female, who had blurred vision in the left eye, had both eyes cataract NS1 to 2 grade, AC was quiet, cup disc ratio was 0.4. There was no peripheral lesion, but left eye had a macular hole with subretinal fluid. Visual acuity in the right eye was 6.9, left eye was 6.36. Patient was non-diabetic and non-hypertensive. So you can see here, this is the left eye. You can see the macular hole. We did an octa in this patient, and the reason why we did the octa, I'll just share with you subsequently when the hole closes. So this is at the superficial capillary plexus. You can see the hole, you can see the plexus. This is at the level of the ORCC. You can see the RP shining through, and you see this hole here. And this is, I will not go into the indices of the hole, but this patient had a base of about 982 microns. So this is a small little video. We have used ICG here. This is just to we normally do it with the chandelier to basically to get a better video. So you can see the hole. Essentially, the vitrectomy is done, followed by use the tricot. So I'll be injecting tricot after. So the tricot has been injected, and induce a PVD, and the PVD has been induced, and subsequently most of it is, then we stain it with ICG. You can see the flaps being made. So this is Sometimes the instrument doesn't hold because we reuse our instruments, but can't help it. I didn't wish to edit this, but very irritating when it doesn't hold. So there are 3 flaps now. We'll get one more and then enlarge the. So these are multiple flaps, and you will see that these flaps actually are able to, if you nudge them a little bit without pushing them onto the whole area, they do stick together. Some people use PFC in these cases so that it stays there. And the reason why they hold, I'll just explain to you, and then the fluid air exchange is done. And this is, I use SF6. So we used SF6, a fluid gas exchange has been done. And that is the end of the slide. Sorry. End of the surgery. So this is what the patient came back to me about 2.5 weeks later. This is on 6th of February. And you see a nice hole closure. If you look at the DCP slab, you find there's a good closure. You look at the ORCC slab, also there is a good closure. The patient's visual acuity has improved to 618. This is just 2 weeks. This is the comparison. This is what the patient's pre-op presentation. This was on the 16th of January, got operated on 18th January. This is on 6th February with the ILM flaps lying here and the hole closed. So we published this technique in ophthalmology surgery called the cabbage leaf inverted flap technique. And this was the case we had presented. This was pre-op, ILM 3 flaps. This was the inverse ILM cabbage flaps. And this was the patient who had actually a very large hole. This was almost about 1.18 or 1.2, if I remember. It was a pretty large hole. I was surprised that it closed. This was about 3 weeks later. This is about 14 weeks later. This is 3 weeks, 14 weeks. And this is how the picture was. Now, the rationale which I want to convey to Ruchir also is that large macular hole, they have been traditionally managed by peeling the ILM over the macular hole, which was just the ILM peel. Then came the inverted ILM flap. But if you look at an ILM flap, and a scanning electron microscopy was done on the ILM, and ILM flap has a vitreal surface and a retinal surface. So when you take a temporal flap and you put it backwards, it is the vitreal surface connecting with the vitreal surface on the nasal retina. But when you have a multiplanar flap or a cabbage flap, you will invariably have a flap, which is, you will see here, there are 3 flaps. You will find the vitreal surface of one flap will overlap the retinal surface of other flap, and this will work almost like a Velcro tape. So when they come together, they join with each other, they will stay together. You have to sometimes nudge them to get them closer to each other, otherwise they will not stay. And sometimes PFCL helps in these cases. And once that happens, they will not get loose. So the take-home messages, you have multiple flaps, where the one surface, which is the vitreal surface, connects with the retinal surface, and when they overlap, is going to give a good macular closure. And also, possibly, when they have a good closure, it forms a closed cavity where probably that's what we propose. I'm not sure, where the RP would act as a negative pumping mechanism to keep the cavity dry and the hole closes. So this is my take on it. Thank you very much.
Thank you, Ajay. It was a very nice presentation, and it was a beautiful video. And you have described the cabbage flap beautifully. I think with this, should we close, or if there is any question?
Any comments by Anirudh and our invited faculty?
I think this is more a safe method, because if one flap doesn't work, the other flaps actually takes over, and
Right,
I do the similar technique.
Yeah.
Sir, what do you do in a where you have to do a free flap, because that is the most challenging situation, I feel. What is your methodology and a free flap technique where it is a failed macula hole?
I have done with what Dr. Meena has described with the blood. We have done all that, tried that, and then I have also tried with the free flap, harvested ILM from a distant place and put it over there, and then put in some visco on top of that. But I have not yet tried a retinal transplant. Because that I think is the next, because I'm mentally getting geared up to find a patient where I can do that, but I have not yet tried that. But that I think should be a good option eventually. What is your take on it, Anu?
Free flap, we do it, but it's a really a challenging situation. Sometimes it's very difficult to make the flap stay over the hole. Yes, I have used visco flap, but I have not yet tried the retinal graft. One of our colleagues does it. Dr. Rupok does that with a designed Trifine. He has designed a Trifine. And
so in one of the patients, what I did was I went beyond the temporal arcade, raised a large ILM flap, and almost like what oculoplasty surgeons do, a Z-plasty, I turned the flap down. I was sort of a little bit successful, but it required a large amount of ILM being taken away from a distant place. And so that was still anchored at the arcade, but it was not a free flap, yeah.
So what size of hole do you decide to do a flap and not a regular ILM peel?
Less than 400 microns?
400.
I think we probably, but I'm invariably doing a flap in all my cases, yeah, frankly speaking.
What I have noted with my limited experience is that patients who are smaller holes, they do very well with regular ILM peeling. And with the flap, they do less better. I usually reserve the flaps for, the holes which are in fact larger than 500 microns.
No, say that again. I didn't catch your first one. Patients who are?
No, I'm saying that patients who have a smaller hole, like usually my cutoff is around 500 microns.
Okay.
So I usually do a routine ILM peel in these patients. And I find that the visual recovery and their success rates are much better than using a flap. But indeed, in larger holes, it is indeed your technique is definitely a good way to do it.
So would you like to do in very small holes even a ILM peel?
Not really in stage 2 or stage 3 holes, but stage 4 holes over. Yes, in all stage 4 holes I do ILM.
Say a 150 micron hole. Would you still do an ILM peel?
Yes, I would, because I've burnt my finger once with similar kind of case, like the hole was approximately 175 or 200 microns approximately. And I didn't do an ILM peel and I land up with a bigger hole in a follow-up. So it's actually because of that I never get away from peeling ILM in these cases.
So I don't know about this. I've not done that, but there's a large series from Bascom Palmer where I'm forgetting the name of it. It's a very prominent macula hole surgeon. He for smaller holes they were not removing ILM and they were getting hole closure.
In fact, there are some studies which suggest just injecting gas would help in very small holes.
That is like VMT. That is stage 2.
Not audible.
The stage 2 or less would actually be a spectrum of VMT and not a particular macular hole. So I mean, injecting gas technically should help. In a VMT, it does help. So, I mean, that's a different thing altogether. So can I put in one statement? I mean, I could listen to all of you. I mean, in less than 300 micron holes, I generally make flaps, but I don't put them anywhere. I just peel the flaps and let them be. If they cover the macular hole, well and good. If they don't cover the macular hole, I can always go back and put the flaps in. So holes close either ways. So that is something.
Let me ask this question. Do people believe that once you have multiple flaps, whether the flaps would help in the centripetal movement of the retina?
Sir, I too don't believe that.
No, but then how does the hole close?
I somehow feel that it is the drying effect of the flaps that is helping it, and the fact that it is giving a scaffold for the closure to happen.
No, so scaffold for what?
Scaffold for the retina. Okay, the centripetal force, right?
No, scaffold for what to grow there? The retina has to move to the center. Why should a retina which is stuck, which is attached to the retinal pigment epithelium, move to the center?
Sir, my rationale was just that when we did not do flaps, when we used to only do ILM peeling and the hole would not close, most of the people would only just dry the area and then put a longer tamponade. So probably the drying effect was more prominent in those cases. So if I'm putting flaps, I may only be providing that drying effect for a longer period of time. That is what I believe. I do agree with you that the centripetal forces should change, which should help in when the fibrosis happens, it should help in closure of the hole. But I mean, I'm not sure still.
The reason your hole initially did not close was it was a single flap, the retinal surface going over the retinal surface and not getting stuck there.
Right, sir.
But when you did multiple techniques, then they attached to each other, they formed a closed cavity, which did not get any fluid inside it.
Right.
And that probably helped. And then there was it sort of caused an inward movement, and that probably caused the closure of the hole. Because nobody really talks about it, and I'm surprised that, I personally feel that there is a centripetal force working, but no way to prove it.
Sir, I had one last question. Starting brolucizumab only, I mean, I just could not speak up at that point of time. I have given this injection in 4 patients as of now, and 1 is planned for a cataract surgery. And what I heard was that any inflammatory condition could trigger a response. So should I wait in that patient, and how long do we intend to not provide any stimulus, any inflammatory stimulus in such patients?
Anirudh?
Yeah, I think it's we are all actually learning, so it's better to wait for some time. That's what I believe.
Like we give ACCENTRIX in such cases, sir.
This is post-cataract, so I think this might be also something we should keep in mind.
No, but Anirudh, the other way to look at it is that if you wait too much and the patient is due for the next injection and you time out your cataract surgery at that time, you will probably have more inflammation.
No, actually, this can happen with the second and the third injection as well.
Mm-hmm.
So you would never know whether it is because of the cataract or your injection. So better avoid it.
Yeah.
So maybe you should give a Dex implant with your cataract surgery, so that your eye becomes quiet, and then subsequently go back to PAGENAX.
Why not to try any other anti-VEGF, sir? For the cataract surgery as a combination, that's all.
Patients wants PAGENAX.
Okay, then it's okay.
But what if we've already done that? I mean, I have few patients who were planned for cataract surgery and I wanted to dry the macula. So I gave ACCENTRIX, it did not work. Then I gave PAGENAX, now the macula is dry, and now I have to tell the patient to not get the cataract surgery done. It's a very difficult predicament for the patient.
So maybe you should report this by giving a Dex implant, and then so that gives you some time for drying effect, because even the Dex implant has got an anti-VEGF action. So that might help you. And then subsequently switch over to brolucizumab while the DEX implant is working. And then it should work. So I would in such cases, I would give a suprachoroidal triamcinolone.
I'm yet to try that, sir. I will come and see you once before.
Yeah. We've had now a fairly large series of cases, but it's not supported by multinationals.
I still give IVT.
IVT, अच्छा नहीं I give only suprachoroidal. IVT बहुत very little. Chalo, Goel sir, should we close it? I think our first meeting was, I hope you enjoyed it.
Yeah. It was a very nice, nicely organized session. And we are very thankful to all the speakers, especially Dr. Anirudh, Dr. Ajay Dudani. So they had thrown a light on this.
हमने उनको जबरदस्ती member भी बना लिया, sir.
Very good.
I think I hope they don't mind it, but I think being here working in Noida, it's good idea to be members of NOS, and we should really become very energetic society academically.
Yeah.
And we'll have Anirudh more often with us.
Good.
Yeah. Thank you. So I think thank you all very much, and thanks Sunil for all the support.
Thank you.
Must say that we should, though I think I should have done that earlier, we should thanks Novartis for all the help they provided in sponsoring our session, and thank you all very much.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Good night.
Okay, thank you.